Scroll up to the beginning.
Hello, everybody. Welcome to our Orthopedic Anatomy Series. This is our fourth event. Thank you for tuning in. This is going to be the Exploring Your Body from the Inside Out Hand and Upper Extremity edition. I'm Elena Kachan, Field Marketer at OrthoCarolina, and I'll be your host today alongside Rachel.
And I'm Rachel Klaus, Director of Academic Services at Experience Anatomy.
If you're tuning in for this event series for the first time, we'll give you a little bit of background. At OrthoCarolina, our goal in 2020 was to create a series of events to educate you on your anatomy and explain what actually happens to your muscles, bones, and joints when you're in pain. We set out to highlight a variety of orthopedic topics so you can get all of your questions answered by our team of doctors alongside the experts at Experience Anatomy.
For those of you who don't know Experience Anatomy, we are the premier anatomy education company specializing in training and education using real preserved human specimens. We are fully outfitted with a cadaver lab and human plastinates, which allow you to see what your muscles and bones look like under your skin. Here's a quick look at what we do. Welcome to Experience Anatomy, where we're dedicated to providing the highest quality anatomical specimens for all levels of training. This is our classroom and conference center designed for intimate learning, virtual sessions, and larger panel discussions. This is our multifunctional lab space, fully equipped as a mock OR, where we host cadaveric dissection and surgical training. Our lab is the ideal setting for educators, researchers, medical professionals, first responders, and military personnel to develop and hone their skills. We are committed to facilitating cadaveric tissue study using a proprietary soft embalming technique in a rich, authentic, and convenient learning environment. Experience Anatomy, where education meets application.
Scroll up. With the recent changes in our world, this program has been adjusted to be completely virtual, so you can tune in wherever it's convenient for you. The entire video will be available after the event, so if you missed anything, you can watch it back later and share with a friend if you find the information helpful. So today we'll be discussing the ailments of the hand, wrist, and elbow. We'll touch on carpal tunnel, trigger finger, tennis and golfer's elbow, fractures, and more. We'll discuss what that means when it comes to your care and what appointment and potential treatment can actually look like.
This is a virtual event streaming live on Facebook and YouTube, so this is your opportunity to ask our hand doctors anything. We've got a panel of physicians ready to answer your questions at the end. If you already know what you want to ask, comment on our live stream below or on whichever platform you're watching, and we'll be sure to discuss.
Now let's meet our panelists for tonight. Hey guys, thanks for joining us today. Why don't you all introduce yourselves so we can get to know you a little bit, where you typically see patients, any other information you'd like to share about yourselves. Let's start with Dr. Briones.
Thanks, Elena. Hi, I'm Dr. Marcus Briones, and I'm an orthopedic surgeon. I specialize in surgery of the upper extremity, which includes the shoulder, elbow, wrist, and hand. I work primarily out of the Monroe office, but also see patients in our Blakeney office. I operate out of Atrium Health Union, Novant Matthews, as well as the Matthews Surgery Center. Thanks for inviting me to participate, and I'm looking forward to a fun and informative show.
Hi, my name is Erica Gant, and I'm also excited to be here. I practice in our Charlotte office and in the Huntersville office. I am an orthopedic surgeon as well and specialize in the hand and upper extremity.
Hi, everybody. I'm Dr. Dan Lewis. I'm also an orthopedic surgeon, as well as hand and upper extremity surgeon. I practice out of the Randolph Road location in downtown Charlotte, as well as Matthews. I really appreciate everybody having us on tonight so we can kind of go through your questions and some of the common conditions that we often see.
Hi, I'm Dr. Brian Loeffler. I'm a hand and upper extremity surgeon taking care of patients with conditions from the hand up to the shoulder. I'm also an orthopedic surgeon, and I see patients at our hand center up on Randolph Road as well as our South office.
Hi, I am Dr. Julie Woodside. I practice as an orthopedic surgeon and hand to elbow specialist, and I practice out of our OrthoCarolina office in Gastonia. I'm excited to be here as well.
Awesome. So now that we've met the panelists for tonight, if you have a question, comment on the live stream below and we'll tackle those at the end. Let's take a look at our first segment with Dr. Loeffler as he touches on what the most common conditions are in the hand clinic and what your next steps might be in moving forward when consulting an orthopedic specialist.
My name is Brian Loeffler. I'm a hand and upper extremity specialist at OrthoCarolina. I practice at our hand center locations as well as at the South Park location. I'm an upper extremity specialist, which means I take care of patients that have conditions ranging all the way from the fingers all the way up to the shoulder. We basically see two different types of patients. We see people who have had an acute injury or a very recent injury that's caused a break in the bone or an injury to a tendon or nerve or a blood vessel. And then we also see patients that have more chronic conditions or conditions that have been going on for some period of time. Oftentimes they'll come to the office when they're having pain or things that are interfering with their ability to do their normal daily activities, or if it's interfering with sleep or impacting them in their work. Those are probably the main reasons that people come in to get evaluated and see what is going on and how we can help them. One of the most common reasons that patients will come to see a hand surgeon or come to see myself is for a condition called carpal tunnel syndrome. Carpal tunnel syndrome occurs when a nerve that's going down the forearm and into the wrist is getting compressed at the level of the wrist. And when a nerve gets squished in this condition or compressed, it can cause numbness, tingling, burning pain that goes into the hand and into the fingers. During the course of a visit, we can examine the hand to determine if in fact that's what the condition is. And then after we have honed in on the diagnosis, then we can discuss it with the patient, what the treatment options are going forward. Carpal tunnel syndrome really has three types of treatments that work for it. For some patients, we start with just using a wrist brace, which they can wear at night. And it prevents them from kind of curling up when you sleep. And that can give the nerve some rest. And it can actually help with a lot of the symptoms like pain and numbness and tingling and waking that can occur. A second treatment option for carpal tunnel is to do a steroid injection. And what we do is we know exactly where the nerve is and how to get right next to it. And we can do a little injection of steroid into the wrist that can help calm down the inflammation and reduce the pressure on the nerve. Sometimes after trying a wrist splint or using an injection, the symptoms persist, or maybe the symptoms are very severe and they didn't really respond to those other treatment options. We can do something called a carpal tunnel release. And we just numb up the hand, we make a small incision over the palm, where we can take all the pressure off of the nerve. And we describe it as saying that it allows the nerve to wake back up. And that can eliminate the numbness and tingling and even weakness that can develop into the hand when you've had pressure on a nerve for a long period of time. Oftentimes these surgeries are done in an office setting with just local anesthetic. Afterwards, we allow the patients to use the hand right away. They can use it for light things. They wear a dressing over the hand or to keep it sterile. And then after a couple of weeks, we'll remove the stitches, make sure that the hand is working well. And then we'll usually restrict putting any real pressure on the palm or doing any heavy lifting for about 4 weeks after the surgery. After that, it's a gradual return to all activities. One of the other conditions that we see often in our office in evaluating patients is arthritis. And arthritis can affect the wrist and it can affect the hand as well. So this particular patient came in with a lot of pain at the base of her thumb. And what we see when we look at her x-rays is we see a severe amount of arthritis in the thumb. So if you look at some of the other joints within the hand, you'll see that there's a space between the bones here at the joint, and that's where the cartilage is. In this patient's case, the cartilage has been completely worn down, and so now she has bone on bone. There's absolutely no space between the two bones there. When we first see people with these conditions, we like to start with conservative treatment. Things like taking anti-inflammatories or Tylenol, wearing wrist braces, or types of devices that can immobilize the joint to rest it and protect it. If patients have had those treatments and they're still having pain, in some cases we'll give a steroid injection. But if someone has had all of those conservative type of treatments and is still having significant pain, fortunately in the hand and wrist we have some really good treatment options for these arthritic conditions that are surgical. For the base of the thumb, which is the most common type of arthritis that we see in the hand, we can do something that's like a joint replacement, like you may have seen for a hip or a knee or a shoulder, for example. But we don't use implants. We use all your own stuff, as I like to say. So we use the tendons that you have in the wrist to create something that's like a joint replacement that can work really well. In the elbow, the two of the most common conditions that we see are called tennis elbow or golfer's elbow. So tennis elbow is a type of tendonitis that affects the outside of the elbow. Golfer's elbow is where you have a similar type of tendonitis on the inside of the elbow. It's a condition where the tendons, where they're attaching to the bone there, can get little partial tearing in them. And it could be from repetitive use or from a specific injury, or it could be something that just happens over time. But we have a lot of different treatment options available that can help to get the pain improved and allow people to get their strength back in the hand and get back to doing everything that they like to do. One of the most common injuries that we see in our practice is something called a distal radius fracture, and that's a type of a wrist fracture. And the treatment options for distal radius fracture really depends on what the bone quality is like and how severe the fracture is. When possible, we like to treat them non-operatively with a cast. But if we see that there's significant deformity or if there's a fracture that goes into the joint, we like to fix those because it can allow patients to get their range of motion, strength, and function back as quickly as possible, but it also can prevent problems from arising in the future. One of the most common injuries that we see around the elbow is a tendon rupture, where the biceps tendon, as it inserts on the bone or attaches to your radius bone, can pop off. That can be from an injury where there's a big load coming to the elbow and it causes a forceful extension. It actually causes the tendon to pull off completely. When a tendon completely pulls off of a bone, unfortunately, it can't heal on its own. The only way to get it to go back to where it belongs so that it can do its normal function is to reattach the tendon to the bone. We'll talk to them about whether they're a good candidate to have a repair to reattach the tendon to the bone. As a hand and upper extremity specialist with the added training of working on just the arm, we become extremely familiar with the intricacies of the anatomy. We know exactly how to get to those structures safely to protect all the other structures, go in and fix the problem. We really take pride in the ability to take care of the community, and we're always looking forward to taking care of people who have conditions that affect the hand all the way up to the elbow and even shoulder. And so we love to have patients come in and visit us at our different locations. If you have a condition that's affecting your hand and upper extremity function, find a hand specialist at one of our office locations. I'm at the Hand Center and at South Park, but we have hand specialists at many of our offices around the Charlotte area. You can come on in, we can take a look, get to meet you, figure out what's going on with you, how it's affecting your life, and what we can do to try to help you.
Wow, thank you for that, Dr. Loeffler. That was a great explanation. Turns out there are a lot of potential ailments that can occur in the elbow, wrist, and hand. Our wrists and hands are responsible for a lot of the fine motor skills that we use, like typing, buttoning a shirt, and texting. Not to mention how many hours we really spend each day doing those things.
I spend tons of time at my desk and typing, texting, so I'm constantly having to take breaks and give my hands a good stretch just so they stay mobile and don't get stiff. So I totally get that. For those of us joining, if you're watching Orthopedic Anatomy event, the 4th one of this year in partnership with Experience Anatomy. So Dr. Gann, I have a question for you here. What symptoms does someone with carpal tunnel experience and why? Can you prevent it?
Yes, a lot of our patients with carpal tunnel syndrome present with numbness and tingling in their hands. And oftentimes they'll experience these symptoms at night or early in the morning when they first wake up. And it's that kind of sensation like they're having to shake their hands out to get the feeling back in them. And so it's often a myth that it happens just with typing, because again, the majority of our patients first experience it usually at night in the early mornings. For the majority of patients with carpal tunnel syndrome, we use a term called idiopathic, meaning we don't know why they develop them, and it's really not preventable. There are patients who develop carpal tunnel syndrome after an injury, but for the vast majority of patients, we don't really think that it's preventable. There are some medical conditions where patients are predisposed to carpal tunnel syndrome, such as diabetes or thyroid disorders. There are some other medical conditions where you might be more at risk for developing carpal tunnel syndrome.
Thanks for that insight. I know carpal tunnel is one of the most common questions we get asked about, so that's really helpful to hear from your perspective. Just a reminder out there, if you do have a question for the panel, please add it to the live stream chat below and we'll tackle those at the end. Before we head into our next segment, Rachel's going to give us a quick overview in the Experience Anatomy corner using the plastinets at Experience Anatomy.
Hey, welcome to the Anatomy Corner. I'm going to do a brief overview of some anatomy before we dive into some more detailed anatomy in the next segment. So first I want to cover how the elbow functions. So this bone here is the humerus. It's the bone that forms the arm, and it articulates with the ulna and the radius here at the elbow joint. So here I'm holding the ulna, and it articulates with the humerus, kind of like this, and it moves like this, which we're all used to with our elbow joint, right? And so if I bring in the radius, you can see where these two bones lay. So maybe you do or don't know already that the forearm consists of 2 bones, while the upper arm, just the arm, consists of 1 bone. And whenever you turn your hand over or pronate your hand, these 2 bones actually cross over each other. So you can see that here in this sort of demonstration I'm trying to do here. So these 2 bones cross over each other in the forearm. And so here I have a full arm specimen, and all the muscles here on the inside of the forearm, or here on the inside of the forearm, they flex the wrist. So they bring the wrist towards your elbow. And all the muscles here on the back side of the forearm, or back here, they extend the wrist. So they bring your wrist backing up like you're waving hi. And so this is important to understand some of the injuries that occur with tennis elbow and golfer's elbow, right? Because you're either overusing the flexion or you're overusing the extension of your wrist, which can cause fatigue in these muscles and tendonitis where they occur up in the elbow. Now, as far as the hand is concerned, there are 27 bones within the hand. That's not including the radius and ulna. So here at the wrist, you have about 8 carpal bones, which allow you to move your hand in this type of fashion. And then there are bones within the palm of your hand and within your fingers, which allow you to do all these fine motor skills. So let's go ahead and jump to our next segment to look at more detailed anatomy and learn what kinds of problems might occur with these different anatomical structures.
Hi everybody, I'm Dr. Dan Lewis. I'm an orthopedic surgeon and a hand surgeon at OrthoCarolina. I often work at the Hand Center at Randolph Road as well as Matthews. So we're going to take a look at this specimen right here. This is the bony anatomy of the end of the forearm, the wrist, as well as the fingers. The two bones of the forearm come together here to form the wrist joint along with the 8 bones of the wrist. There's the radius bone and the ulna bone, which again are the 2 bones of the forearm, which connect together and control the rotation of the forearm. As we get to the fingertips, are the metacarpal bones to the thumb, index, middle, and ring fingers. And then as we come out to the rest of the hand are the phalanges. So one of the most common conditions that patients come in to see a hand surgeon for is carpal tunnel syndrome. And carpal tunnel syndrome is actually a compression of the median nerve that occurs in the carpal tunnel, which is an actual anatomic space. And we can see this is the left hand with the palm up position, like so. There's a strong ligament that connects these bones together that rises over top like an arch. The nerve, the median nerve, passes through that tunnel with 9 tendons that flex the fingers down. With carpal tunnel syndrome, there will be pressure exerted on the median nerve, which can cause numbness and tingling to the thumb, index, middle, and portion of the ring finger. Another common condition that I see in the clinic is trigger finger. And what trigger finger is when the tendons that come down again through the hand out towards the finger become compressed within a tunnel called the flexor sheath or flexor retinaculum. This area right here is called the A1 pulley, and we could see the 2 tendons that bend the finger down, particularly this example is the ring finger, will pass into this tube as it moves out towards the fingertip. This tube will become thickened and less pliable. That creates drag and results in inflammation and swelling of the tendon. This will create a snapping type sensation that occurs in the finger that could also be quite painful. The second most commonly compressed nerve in the upper extremity is the ulnar nerve. The ulnar nerve can be compressed through this space, most commonly called the cubital tunnel. As the ulnar nerve travels down from the arm, it'll pass through a canal right behind the elbow as it moves towards the hand, and then eventually will provide the sensation to the small and ring finger. One of the most common complaints people have who have cubital tunnel syndrome is not only numbness and tingling into the ring and small finger, but they feel like they cannot use the hand to do fine motor activities such as buttoning their shirt or shaving.
So here at Experience Anatomy, we specialize in preparing soft embalmed cadaver specimens that can be utilized for surgical training. In front of us here we have a cadaver arm from an individual who decided to donate their body to science for education. And so here we'll dive in and take a look at some of the anatomy of the arm that is performed during elbow, wrist, and hand surgery.
Carpal tunnel syndrome is when the nerve becomes compressed in this space. The operation to release the nerve is called a carpal tunnel release. So we typically, for carpal tunnel release, an open carpal tunnel release, will make an incision in the palm, in the proximal portion. Palmar fascia is divided. The transverse carpal ligament is right there. And we will go ahead and divide that. The median nerve is now visible after the transverse carpal ligament has been divided. This is one side of the ligament, and the other side is on this side, right here at the tip of my knife. That ligament has been divided. The fibers move in this direction. And now we can see the deep structures of the median nerve and the flexor tendons, which are visible deep. The nerve has been decompressed by releasing this thick ligament. The surgery for trigger finger is in this location right here where the problem is, where the tendons pass into the first part of a tube that goes from this location out towards the tip of the finger. An incision is made from the base of the finger towards the distal palmar crease in this location. The skin is incised and the subcutaneous fat is swept away. And we can now see the tube that the tendons glide within. This is where the tube has become thickened and is compressing the tendons. We will take a scalpel and divide the tube longitudinally. Scissors will complete the release distally, and then proximally. And now we could see the flexor tendons that bend the finger down are completely free in this location and are able to glide. So when patients develop cubital tunnel syndrome, the ulnar nerve or funny bone is pinched in this location called the cubital tunnel. We're going to perform what's known as a cubital tunnel release. An incision is made on the inside of the elbow. This is the olecranon, or the back of the elbow, the pointy part, and this is the inside of the elbow. The incision that I'm making is going to be a little bit larger than what I typically make in surgery so that everyone could see. And then we dissect through the subcutaneous fat. During the operation, we decompress the nerve as it passes through this thick tube that is surrounded by a thick ligament and bone. So we very carefully, while we protect the nerve, we'll cut the overlying ligament. Cut the fascia of the muscle, carefully spread and cut the muscle, doesn't damage it at all. The thick ligament that creates the roof of the cubital tunnel and was creating compression on the nerve has been completely released, which frees up pressure on the nerve. I'd like to thank you for joining us. Hopefully this demonstration has provided education on multiple conditions that affect the upper extremity. If you are having any of these conditions or any other conditions that affect the hand, wrist, or elbow, feel free to reach out to OrthoCarolina to schedule an appointment with one of our providers. Again, my name is Dr. Dan Lewis. I practice at the Hand Center on Randolph Road in downtown Charlotte, as well as the Matthews location. I hope you the best of health, but I am here if you have any other issues, questions, or concerns, and be more than happy to see you in one of our offices.
I love the fact that we got a chance to see such an up-close view of what actually would happen in the OR. Thanks for that, Dr. Lewis. I definitely want to throw it over to the panel to see if there's anything else they'd like to add to that. I have a question for you as we move forward. If you have multiple trigger fingers that require an operation on one or both hands, what happens next? How does that work?
Sure, that's a great question. Trigger fingers tend to be one of the more common things that we see in our orthopedic hand practice. And typically we start out always with conservative management, oftentimes with 1 or 2 injections. And patients can get excellent relief with injections, but occasionally those don't work long term, which oftentimes will prompt consideration for doing surgery. What it really comes down to when we decide on surgery is how much pain are you having? How much is this affecting your day-to-day function? And if it gets to the point where it's significantly impacting those things, then we will proceed oftentimes to an operating room, or up at the Hand Center, they have a minor procedure room where they're able to do these procedures. If you have more than one trigger finger, or if it's bilateral, I often will give you the option of taking care of all of the trigger fingers at one time. Having it done bilaterally is definitely going to affect your postoperative course a little bit more as far as affecting day-to-day activities, and you'll certainly need to spend a little bit more time recovering. But what you're describing is a typical Monday afternoon for me in the operating room. Just this past Monday, I had one patient where we released a carpal tunnel, a thumb, as well as a ring trigger finger, and another patient where I did bilateral ring trigger finger releases. So yeah, we try to cater it to each patient and take care of the problems that need addressed.
Awesome, thanks for that insight. We're moving on to the next topic. This question is for you, Dr. Woodside. Do the released tunnels grow back or remain open when it comes to carpal tunnel?
Thank you for the question. And this is actually something that we get asked very frequently, that and as well as the trigger finger, because with the trigger finger, as you saw Dr. Lewis releasing the pulley above the tendon. And so in the carpal tunnel release, we're releasing the ligament that's on top of the nerve and the tendons in the carpal tunnel. And so people frequently ask us if this grows back together, will it recur? And the answer is yes, your body heals just about everything that we're cutting, but what it does is it heals separated out. And so that's what gives you that release underneath it, is you're getting a more spread out healing of that. So what we wanted to do is heal in a looser fashion in for both the trigger fingers and the carpal tunnel.
Awesome, thanks for that. If you're just now tuning in, you're watching OrthoCarolina's 4th Orthopedic Anatomy event, Exploring Your Body from the Inside Out, Hand and Upper Extremity Edition with Experience Anatomy. So this year, we've covered in-depth topics when it comes to shoulder injuries and care, spine ailments and treatments, hip and knee pain relief, and today we're tackling the hand, wrist, and elbow with a few of our experts, as you've seen. It's really cool to get a behind-the-scenes look at this amazing work, and if you like this type of content, OrthoCarolina has live streamed fewer smaller procedures such as the trigger finger release and carpal tunnel surgery in the OR, and you can check them out on our Facebook page at OrthoCarolina. Now, please submit your questions below if you're watching live, because right now we're going to move into our Ask a Doctor segment to get all of your burning hand-related questions answered by our panel. And we can head into that here and now. All right.
Perfect. So the first question on our lineup is worded, I'm 69 years old with pain in the thenar area of my left hand. So that's the thumb side of my left hand. I'm also starting to get pain in the same region of the right hand. That area tends to feel warm, which I assume is inflammation. Can I assume this is coming from arthritis? Can I get relief without pain medication?
And we're going to throw that to Dr. Gant, please.
So that is unfortunately a very common thing that we see, particularly in our patients, usually as early as 40 and older. Thumb arthritis, which is in that muscle that Rachel was showing, it can be incredibly disabling and painful. It's hard to work around your thumbs. And we actually see this condition slightly more in women than men. And the treatment for arthritis in your thumb, which is basically that term, when we use the term arthritis, it's a loss of cartilage or padding between your joints. Whether it's in the thumb or in your hip or in your knee, we really try to walk you slowly through the treatment options, from bracing to medications such as Advil or Aleve type drugs if you don't have a reason why you shouldn't be taking them. And of course, you have to be careful about overtaking those kinds of medications. But often we will try cortisone injections, and then finally surgery if we're unable to take care of that pain. Because again, having pain at the base of your thumb is quite disabling and pretty hard to do any kind of grip or heavy strength activities with that form of arthritis.
Great, thanks for that insight. This one's for Dr. Loeffler. When should you get surgery for trigger finger? And we'll start with that, and I'll have a follow-up question.
All right, great. Thank you. Well, I think Dr. Briones explained it pretty well, and you saw Dr. Lewis in the lab showing us how it's done. But when we've tried conservative treatments and those have failed, and it's still symptomatic, meaning that there's still pain or locking and catching in the finger, despite trying things like steroid injections, if it's affecting your daily life, things at night, kind of waking you up or waking up with a painful trigger finger, that's the time to consider having the release done. And fortunately, that's something, again, we can do in the office under local anesthesia in some cases. So it really minimizes the inconvenience for the patient, and it works well.
I was wondering, after trigger finger surgery, how long does it take for the pain and the stiffness to go away? What's the recovery like?
Heal differently. And so sometimes people will recover very quickly. They'll have, full motion right away and they have minimal pain with it. And there's some other patients that will have some stiffness in the finger and it can be sore in the palm, even for weeks or even in some cases months. And sometimes if a person comes in with some loss of motion or if the trigger finger has been present for a long period of time, then they're kind of predisposed to potentially having a longer recovery for it. So in general, I would say we take the stitches out at about 10 to 14 days, and we want you moving it right away. But it's not uncommon at all to have some soreness in that area, for a few weeks or even a month or two.
Great, thank you so much. So the next question is, I'm told I have writer's cramp. I have seen 5 different doctors and nobody knows what to do. Do any of your doctors know what to do? Dr. Lewis, can you tackle this one?
I sure can. So writer's cramp is a pretty common term, and what it really is medically, the term is focal dystonia. And what dystonia is an abnormal contraction of a muscle, which means the muscle contracts when you don't want it to. So that's when you get that spasm or cramp, if you will, if you're pinching something or holding something in your hand. I've had patients get it after cutting steak. People get it who play string instruments such as violin, or people who play piano. Professional musicians can get it in other fingers other than in their thumb and in their index finger. So it can happen to any finger, but it's called focal dystonia is the medical term for it. The mainstays of treatment is definitely occupational therapy. There's several different types of occupational therapy can be done, but mirror therapy is the most commonly used treatment for this, and that's getting there's a disruption between the brain and the extremity, or the hand and fingers, if you will, that's causing this muscle and nerve to fire without you thinking about or wanting to do it. So it's basically deconnecting that neural pathway, and it's been quite successful. So definitely therapy is the main stay of treatment, at least at the first several visits we see them.
Great, thanks for that. This one's for Dr. Woodside. What is the difference between carpal tunnel and repetitive stress injury? Can the pain radiate as far up as your neck and shoulder?
Yes, so we often see carpal tunnel syndrome and compression of the nerve as it comes out of the neck going on together. And I think part of what the spine doctors and the hand doctors are trying to figure out is kind of which problem is causing the symptoms. It is typically much easier on the patient to deal with some of the symptoms lower down in the arm first, like the carpal tunnel syndrome. That can be treated with bracing, injections, and then sometimes surgery. And so oftentimes we'll see that the pain of the carpal tunnel goes from the palm and can go all the way up the arm. People will typically say like right to their bicep, they feel it shoot right up to there. And occasionally I see people tell me that it hurts all the way up towards the shoulder. And if you think about where that nerve is coming out of your neck, coming all the way down your arm, underneath the bicep, and then coming down to the palm, you'll see that that pathway is there for the pain to shoot up and down. And so I think we typically see that it's not isolated right to the palm, and that a lot of patients have this shooting pain up and down their arm. So it can be all from the carpal tunnel, but we typically see some cervical compression of that same nerve as it comes out of the neck that can go along with that as well.
Wonderful. So everything is attached, it seems. So Dr. Briones, I have another question for you. It is, can statin cause muscle and joint pains, and are the side effects from statin permanent?
Yeah, that's a great question. Statins, which are cholesterol-lowering medications, one of the more dangerous side effects of it is a condition called rhabdomyolysis, which can cause an abnormal breakdown of muscle that can affect kidneys and other organ systems. In addition to that, which can be, and thankfully is typically very rare, these medications can cause joint pain and other types of muscle pain. Usually, when you discuss this with the primary care physicians who have prescribed it for you, they will discuss with you discontinuing the medication, and the majority of the time, these types of symptoms will resolve. As far as them being permanent, I'm going to ask the rest of the panel if you know what whether or not in the literature they're describing any permanent muscle or joint pain after discontinuing the medications. Any of y'all know?
Well,
go ahead, Brian.
Well, I was going to say what patients have told me and what I've read is that typically those muscle pains, or myalgias as they can be called, they tend to resolve when the patients come off the statin. So oftentimes we'll recommend that a patient sees their primary care provider or whoever's managing that statin, and perhaps they need to be placed on a different type of medication that may not have that side effect. And that seems to help alleviate those symptoms.
Yeah, and it typically tends to be dose dependent as well. If you're on a lower or starting dose of a statin, usually don't see that problem as much. But patients who are on a little bit larger dose for their cholesterol, you may see that more frequently.
Great, thanks for that, guys. This question is for Dr. Gant. What causes a ganglion cyst, and what happens if it goes untreated, and what non-surgical options are there for relief?
So, ganglion cysts are one of the most common things that we see, or bumps in the hand. People will notice these knots on the top of their wrist, or their family members will note them. And of course, for many people, there's a concern if there's any kind of growth in the hand. But again, these are completely benign. These are not cancerous lesions. And think of them as a balloon filled with jelly. And just like you blow up a balloon, the cyst begins either on a joint or on a tendon. And it's basically filled with this liquid jelly type fluid. So it's completely benign. So for some patients, it's simply coming in and being reassured that this is not a cancer. But we're not sure why people get ganglion cysts. We think it could be trauma. Sometimes boot camp type exercises or repetitive use of the hand and wrist can cause a cyst. But for many people, they can't remember a discrete injury that caused the cyst. If they're not hurting, we tend to want to observe them. And then if they cause pain, there's a number of different treatment options that we have. One includes simply trying to drain the cyst in the office. We might also add steroids to the cyst to see if that will help take the cyst away. And finally, surgery. But I will add that ganglion cysts are one of those stubborn things that we treat in medicine. And often, even with all of the different ways we have of treating them, they can come back. So again, if they're not bothering patients and we can just reassure them, we often say don't do anything about them if they're not hurting you.
Wonderful. Thank you for that insight about ganglion cysts. So the next question is for Dr. Woodside. If a nerve conduction test does not show you have carpal tunnel, but you have all of the symptoms, is it possible that it could still be carpal tunnel?
Great question. And we see this actually more frequently than you might imagine. So typically we will have a patient that has nocturnal or nighttime symptoms of numbness and tingling, may have been relieved by wearing a brace, but then over time that stopped working. When we're in clinic, we have certain tests that we do to test for carpal tunnel by compressing the nerve, by bending the wrist. And when all of those things line up and say, yes, these are all positive and are showing us carpal tunnel, and we're ready to maybe do surgery, we would typically get that nerve conduction study. When a patient comes back with a normal nerve conduction study, plus all of those signs, I would typically recommend to them trying a diagnostic steroid injection. The result from that injection will typically show the patient and the doctor what the result of surgery will be. And if all of those things line up, and then you have a great response to the steroid injection, then you would usually have that good response to surgery. So yes, we do see patients with carpal tunnel syndrome have normal nerve conduction studies. It's not uncommon. And I don't know if anyone else has any comments on that, or if they have a different method they go about after a patient has a normal test.
Yeah, my treatment algorithm is very similar. If somebody comes in, they have classic symptoms, but a normal nerve study, I explain to them that it's a clinical diagnosis. And I oftentimes will do the same thing, offer the steroid injection. So.
Great, thank you very much. And just as a follow-up to that question, if someone does pursue surgery for carpal tunnel syndrome, how long after that surgery would they be able to use their hand?
That's for me as well, I'm assuming.
Yeah.
So I typically do what's called an endoscopic carpal tunnel. And that kind of brings the incision off the palm. So it's kind of at the wrist. And I typically use something that looks just like a Band-Aid. For that reason, I want my patients to use their hand to the fullest extent that they want to from day one. So I typically allow them to go back to all activities as soon as they feel comfortable. And I think that really depends on everyone's pain tolerance on when they can actually achieve that.
Great. This one is a combo question, and I will throw this to Dr. Loeffler. What causes trigger thumb? Is it different than a regular trigger finger? What non-surgical options are there for relief? And is there a limit to the number of cortisone shots that can be applied? Sorry for 3 questions in one.
I'll see if I can remember all those. Trigger thumb has the same pathology or the same condition that you get with trigger fingers, the other fingers. It's one of the more common fingers to get affected. The one nuance or the one difference is that you really only have one tendon that bends the thumb down as opposed to the other fingers, because there's 2 joints, there's a tendon for each of those joints. So actually steroid injections work a little bit better in trigger thumb than they do in the other fingers. So again, that's the non-operative treatment for it. Another thing that can be tried for trigger finger, especially if you're having a lot of symptoms that are just at night or while you're sleeping or just in the morning, is you can try putting a little soft tape or wrap around the affected finger. And what it does is it prevents you from sort of curling up at night and aggravating that tendon where it's getting stuck in that tunnel that Dr. Lewis showed us. So that's one of the other non-operative treatments that can be performed. But if it fails all those other treatments, then the surgery, again, works very well for it with an extremely low recurrence rate.
Great, thank you very much. Here's an elbow-specific question. What are some ways to prevent tendinitis of the elbow? Dr. Lewis?
Yeah, that's a great question. So there's several different types of tendinitis that can affect the elbow. There's the tendons that cross the front of the elbow. Bicep is a common tendon that can be irritated or even ruptured, like Dr. Loeffler spoke about in his segment. There's tendons on the back of the elbow. The tricep tendon can also be injured. But what we're more commonly going to see is what's called tennis elbow or golfer's elbow. And tennis elbow is the tendons or the fascia of the tendons and muscles on the outside of the elbow that get kind of overused, or just as we get over 40, it just seems like that tissue just starts to degenerate. And golfer's elbow is the similar thing, but on the inside of the elbow, when it's a similar pathology, that the fascia and the tendons of the muscles that come off that bend the wrist down and flex the fingers down can be overused or irritated. The prevention really is just good hygiene as far as typing and using your extremity like weightlifting. Make sure your hand and wrist are in you don't want them too far extended or flexed position. If you're typing all day long and your wrist is extended while you're typing, those muscles that raise your wrist up are the muscles that get irritated in tennis elbow. And very similarly with golfer's elbow, it's more of a flexion or rotation of the wrist that could be irritated. So it's really just being mindful of your ergonomics and the hygiene throughout the day of the position of your extremities. And the other thing is stretching and strengthening are the mainstays of treatment. There's good educational resources online if you want to look them up as far as just some simple exercises that you could do. But sometimes it's inevitable that we all, as we get a little bit older, are definitely at higher risk of developing golfers and tennis elbows.
Great, thanks for that. This kind of goes into that, but someone asked if tennis elbow happens all of a sudden, and if it does, what kind of treatment is there? And I know you kind of touched on that, but maybe that's a follow-up for you.
So tennis elbow, I mean, it usually is what we call a cumulative event. It kind of occurs over multiple repetitive stressful events that tear that tendon or that origin of that tendon off the bone, and it irritates that origin and the bone itself. And that typically develops over time, but it's not unusual that could happen after a single event, such as lifting something heavy, or just as simple as bumping your elbow on a doorway as you walk on by. Actually, I had a patient today that happened to them several weeks ago, and then they developed basically lateral epicondylitis shortly afterwards. It definitely can happen either way. Again, more commonly, it's a cumulative event that just occurs with these multiple daily stressors, but certainly could be a single event.
Great, thank you very much. So this next question is for Dr. Gant. It says, I have been working out with weights and push-ups using a bar. I have pain on the heels of my palms. What can I do to correct this problem?
You know, this is one where sometimes it's just simply wearing a better padded glove, and that can help, or even trying to increase the width of the bar, that can help that pain and discomfort just from some irritation. There is a small bone on, the base of your palm called the pisiform, and you can put pressure there and develop some stress. And I don't want to use the word arthritis, but you can create some discomfort and pain similar to arthritis, and actually could be aggravating that. And so that also might be something that you might need to come in and be evaluated for. At the same time, the other side of your palm is right in that joint that we talked about, commonly becomes arthritic for many people as they go into their 40s and 50s. And again, we see it a lot in women. And so that also could be a source of pain simply because you're putting a lot of pressure on the thumb side of the palm. So I think you've got to go back and kind of evaluate the mechanics and how you're lifting, maybe consider some more well-padded gloves, lifting gloves, and then consider the bar and increasing the diameter of the grip on the bar.
Wonderful, and I've actually experienced this issue myself with some yoga, not necessarily with weightlifting, but I find engaging my fingers and more of the palm of my hand helps with distributing the force throughout the rest of my hand. Our next question, this is about the elbow. Does typing tend to exacerbate tennis elbow? Let's go to, who wants it?
I can field that one. I temporarily relocated to a more internet favorable area of my home. So yes, so really with tennis elbow, it's a condition where you have partial tearing where the tendon attaches to the side of the bone. It tends to be a degenerative condition. So something that happens actually quite commonly. It's about 2% of the population that'll get it. It's people in their third and fourth and fifth decades most commonly. But it's a condition where the tendon attachment to the bone weakens with time. So there is a degenerative component to it. But once that process is underway, really any time that you're doing any gripping or reaching away from the body to do any type of lifting, especially with the palm down, it puts a lot of stress on the tendon where it attaches to the bone. So when you're typing, your forearm is in what's called a pronated position where the palm is down. And that can be very uncomfortable because when you're typing, you're actually pulling your wrist up. So it's actually putting stress on the area where there's where you have that partial tearing. So it can be from lifting, but it can be from really any condition where the palm and forearm are in that position.
Awesome, thanks for that. We've got a question here. I'm going to toss it to Dr. Woodside. One woman says she is 76 years old and has noticed a couple of fingers are starting to look curved. Is there anything that she can do to prevent this?
Thanks, that's a great question. So I think there's a couple of things that could cause that. One condition is simple arthritis. And if you imagine two bones sitting on top of each other, if you're wearing out one side or the other, it's going to start tilting in that direction. Preventing the arthritis from developing, that's a difficult problem that I think we all wish we could cure. And typically we're trying to treat the pain that comes along with that. I would say that if you have, especially an index, middle, or ring finger, it might be easy to tape two of them side by side together, just to get them in a better alignment. And I haven't found much luck with just wearing a splint all the time. And I think that might end up impeding your function more so than even the curved finger would. So I think that's something that is a discussion that we would have together, looking at your finger, looking at your x-rays. And that's assuming that it might be an arthritic problem versus something like Dupuytren's contracture, which I think we might have a question on that as well. So I might leave that for when that comes up on our questions.
Wonderful. So the next question I'm going to toss to Dr. Briones. And can you talk about complex regional pain syndrome?
Absolutely. So, yeah, tough problem. Complex regional pain syndrome oftentimes occurs after injury. It can also occur after a common routine surgery. And what happens is the sympathetic nervous system becomes overactive, and it oftentimes can result in fairly significant pain into an extremity, to the point where even simple stimulus like touching your hand, or I've had some patients say that a bed sheet is rubbed over the back of their hand or the side of their leg, and it can be extremely painful, and we call that a dysesthesia. The typical treatment for it is multifactorial, because it takes a team to effectively treat this, and oftentimes it can take months up to a year for maximal improvement. We tend to utilize pain medications, anti-inflammatories, steroids, extensive therapy. Oftentimes we'll even send patients to pain specialists to do special types of injections around the stellate ganglion. We call it a stellate ganglion block. So we have a whole team when we're working on complex regional pain, because it is a very difficult problem to treat.
Thanks for tackling that for us. So this one's going to go to Dr. Lewis. Or signs that your pain in the hands and arms are coming from RA?
So that's a great question. So RA stands for rheumatoid arthritis, which is a type of inflammatory arthritis. And there's a whole class of inflammatory arthritis, which is totally different than osteoarthritis. Osteoarthritis is what we've been talking about throughout this interview, is where the body's cartilage just deteriorates over time. Inflammatory arthritis is when your body's immune system actually attacks the soft tissues and joints, as well as the bones. So what happens in rheumatoid arthritis is it's more of an inflammatory phenomenon. We typically see it in a little bit younger age group, but we could see it in patients in their 60s, 70s, and 80s. So what happens is the joints will become much more swollen, warm, and irritated compared to an osteoarthritis, which usually is just a typical mild ache or moderate ache at rest. It can be increased with activity, where an inflammatory arthritis is typically painful around the clock, even if you're not doing any activity or done anything stressful. Oftentimes, the arthritis is more symmetric with rheumatoid arthritis. So you may notice it in the similar joints on both sides. It more commonly affects the knuckles across here, as well as the wrist joint when it comes to the hand and wrist. It could affect any joint, but those are definitely the most common. So again, just to review, warm, swelling, pain at rest, kind of symmetric findings are a little bit more suspicious for an inflammatory arthritis, where rheumatoid arthritis would be one of the most common types.
Wonderful, thank you for that insight. So we're going to take a handful more of questions. The next one is, how can you tell apart an ECU versus a TFCC injury as far as symptoms and treatments? And can you tell us what those acronyms mean?
Sure. So you're getting a real anatomy lesson tonight. So ECU stands for extensor carpi ulnaris. So E means extension, which is pulling the wrist up this way. Carpi relates to the wrist or the carpus. And then ulnaris is the pinky side of the hand. So that particular tendon, if you're looking at my forearm here, pulls the wrist back and over to the side. And that tendon, you can see it kind of popping out there. That can get inflamed just like any other tendon. It has to travel through a little tunnel through there. And a lot of the activities that we do where we're doing twisting motions and moving side to side can get injured. TFCC stands for triangular fibrocartilage complex. And what it is essentially a little ligament that is in the wrist that connects your radius and ulna bones. And it's a great question because it's often difficult to tell which one is causing the pain because they're really right next to each other. So one of the things we do is we'll ask what type of activities tend to aggravate it. And then when we're doing a physical exam, there's certain maneuvers that we can do that will put more stress on the tendon or pushing directly on the area where the TFCC is, which is right in this area called the fovea. If we still can't figure it out from the history and physical examination, then a lot of times what we'll offer is a diagnostic and potentially therapeutic corticosteroid injection. So if we think the tendon is most likely the problem, then we'll do a very specific injection into that tendon sheath. And just like Dr. Woodside was talking about earlier, if it responds nicely to the injection, that helps with your diagnosis as well. If we think it's a problem with the TFCC, then we inject it into the joint where the TFCC lives.
Awesome, thanks for that. I know we're getting a little bit of an anatomy lesson. Wow, I'm having trouble tonight. Sorry about that, guys. Okay, I'm gonna toss this one to Dr. Woodside. I know you mentioned this earlier, but someone asked if you could describe Dupuytren's contraction and what causes it. I'm not sure if I said that correctly.
Very good. So it is actually a pretty hard word to say and to write down. So typically if you come into our office and you do get diagnosed with Dupuytren's contracture, we have a lot of booklets and handouts on it with that word written down because it tends to be a difficult one for people. So Dupuytren's disease actually runs in your genetics. It's in your genes. Now, sometimes you're the first person to get it. Or once you kind of see what it looks like, you're like, oh yeah, my grandfather couldn't open his hand up all the way. And you kind of remember that, yeah, maybe someone else had that as well. And what it is, the easiest way to think about it is that you almost get scar tissue or a thick collagen that forms in the hands, and it acts as a tether or almost a rope that bends the fingers down. Sometimes you just get nodules, which are typically asymptomatic. But when they form these ropes or cords in your hand, that's when the fingers really get tethered. And that tissue will actually keep you from being able to open your fingers up, typically affecting the ring and small finger most commonly, but we can see it in the thumb, index, middle, and it can be on both hands and even in the soles of the feet as well.
Wow, that sounds like a complex condition as well. So the next question I'm going to toss to Dr. Briones. What bone specifically does boxer wrist affect, and what are the symptoms and treatments?
Boxer's wrist, are we talking about boxer's fracture? I'm most familiar with a boxer's fracture, which is a fracture that's going to typically be seen at the metacarpal head of the small finger. I don't know if I'm answering the question that's being posed.
Yeah, I think
heard
boxer
that.
fracture is probably what we're referring to.
Are we?
Boxer's wrist is referring to a CMC boss, Marcus. I had.
Okay, CMC
Google,
boss. Okay, yeah, I haven't heard that term before. So a boxer's wrist or a CMC boss will be along the base of the long metacarpal bone, where you can have some irritation to the cartilage in the bone at the joint where the long metacarpal bone meets up with the carpus. And oftentimes that irritation to that area will cause increased cartilage formation, increased bone formation, and you'll develop sometimes a painful and sometimes a non-painful area where you'll have swelling and a bump across the back of the hand in that area. Typically, it's treated conservatively, anti-inflammatories, sometimes some wrist bracing. Very rarely will we talk to you about a surgery where we'll make an incision over the area and oftentimes shave down that area where the cartilage in the bone has become more prominent. Thanks for clarifying what we were talking about there. I appreciate it.
That's what we have a panel for, so thank you guys for helping each other out. We actually have a lot of questions coming through, so thank you so much for submitting these questions live. We're going to do 3 more. I know we're going to kind of try to wrap this up with this, but I'm going to send this to Dr. Gant. We've got a question here that asks if you can address overuse tendinitis of all digits in younger patients. So this is our first pediatric question, if you could handle that.
Wow, you know, in this day and age, and particularly with COVID and kind of social distancing and isolation, I think we're all using our devices 10 times more than we would have ever thought to use them. And this is creating some havoc on our hands and wrist. So generally speaking, I've seen teenagers come into my office with severe pain and discomfort in their wrist and fingers, and that's usually tendinitis, where the tendons are inflamed simply because they're being overused. And the answer is really simple. You've got to modify the use of all this technology. You really don't want to go down a treatment plan to try to say that your hands and wrists can accommodate all of this. They really can. I think we've all just got to use, on some level, just basic restraint of all the modalities. So sometimes I'll say to patients, look, try to use your microphone, try to use a different mouse, but ultimately it really is activity modification as the first line treatment for all this overuse tendinitis.
Wonderful. I feel that every day at the end of the day when I'm scrolling through Instagram when I should be sleeping. So thank you. The next question is, I have severe arthritis in the joints between my thumbs and wrists. Is there anything that can be done besides steroids? Let's toss that to Dr. Briones.
Great. So the joint that's going to be in between the thumb and the wrist is typically the basilar thumb joint or the carpal metacarpal joint that Dr. Lewis and Dr. Loeffler, I think it was Dr. Loeffler was describing in his video. Aside from steroid injection, oftentimes some bracing of your thumb can be helpful. We have different types of over-the-counter braces in our offices that we can fit you for. We also have the option of having you see one of our hand therapists, and they can make you a custom brace that could be beneficial. When you're meeting with a hand therapist, they can go through some different types of arthritis exercises, talk to you about some different modalities that you can be using at home, such as warm compresses, paraffin baths. You can utilize anti-inflammatories, both oral as well as topicals. And then aside from that conservative management, then there is options including surgery. Like Dr. Loeffler was discussing, taking the bone out at the base of the thumb joint where the arthritis exists. And that tends to be a more long-term durable solution, which will improve both pain and function.
Great, thanks for that. Now, this is our last and final question. We do have a few more, but we will be following this live stream up with a full comprehensive blog post, just answering your questions and taking everything that everybody has said tonight and putting it in writing. So you can find it on our blog at OrthoCarolina.com. Dr. Woodside, I'm going to throw this last one to you, if you don't mind. Someone is asking, if they delay surgery for a trigger finger, can they cause permanent long-term damage?
Very good question. So the thing that we see most commonly in a trigger finger that has been going on for a long time is actually a contracture of the joint. So people will come in and they won't be able to, it's not ever, this bad, but it's typically just about a 25 or 30 degree contracture at this middle joint of the finger. And that is actually pretty difficult to stretch out after surgery. We typically see a little bit of that lingering around. Typically doesn't limit your function at all, but it's something that a lot of our patients notice. So that's probably the most long-term thing that I see on delaying surgery. Releasing the actual triggering of the finger would not be affected by waiting. And it's mostly that contracture of what's called the PIP, or the proximal interphalangeal joint, that we see.
Great, thanks so much. Now, that was our last question. Many thanks to our esteemed panel for sharing their wisdom and insight. You guys rock. Thank you guys so much for tuning in to this episode of the Orthopedic Anatomy Series, Exploring Your Body from the Inside Out, presented by OrthoCarolina in partnership with Experience Anatomy.
And if any of you are interested in learning more about what Experience Anatomy does, you can find us online at experienceanatomy.com. Thanks!